Hello, this is our part 5 of our systematic approach to ECGs. My name is Matt Strelo, and in this lecture we're going to talk about atrial fibrillation and atrial flutter. So atrial fibrillation, the way I like to think of atrial fibrillation is that it's disorganized electrical activity originating in the atria of the heart. And so I think of it like this, where there's a bunch of areas of the atria all fluctuating at the same time, all releasing electrical currents that's going around, and there's no organized electrical activity. And when there's no organized electrical activity, there's no organized mechanical activity or contraction. And so the muscle is just doing this, and there's never any organized squeeze. In atrial fibrillation, every once in a while, there will be a conducted beat that will go through the AV node, down through the normal electrical pathway to depolarize the ventricle. The AV node is really the gatekeeper then, because there's so much electrical activity going on in the atria that the AV node is blocking it and saying, we're not going to take all of that, we're just going to take intermittently, we're going to take an electrical current and let it go through and depolarize the ventricle. What this looks like then on our rhythm strip or ECG is that we have a disorganized rhythm of the atria, so no real P waves. You might see something that I call a false P wave because patients are often moving and the baseline looks a little bit wavy, but you won't see any regular P waves that look the same in our preceding QRS complexes. Your RR interval then tends to vary. So we would say it's an irregular RR interval. So here's an ECG. We know that I'm going to give you the rate. It's 114. Let's figure out the rhythm. And in order to do that, we want to use our systematic approach. So our first question, right, is the QRS wide or narrow? Well, in this case, if you look, you can see that the QRS looks pretty narrow. So we go into our next question. And our next question is it regular or irregular, the distance between the QRS complexes? And what you see here is that it is very irregular, and those distances are varying greatly. So we're going to say that it's irregular. And then what was our last question? The last question was there P waves present? So here you can see that it's irregular. And we see something that looks like a P wave, but I would call that a false P wave. So you have to be careful. And I like to look at the rhythm strip at the bottom. And at the rhythm strip at the bottom, you can see that there's no significant P waves on this rhythm strip here, where you're going to see a repetitive complex before each QRS. And that shows it in greater detail, where we see no P wave there. So you should see a P wave preceding every QRS complex. And if you don't, oftentimes those are false P waves. So here we're going to say there's no P waves. And what's the most likely rhythm then? It's by far and away atrial fibrillation. So in summary, atrial fibrillation is disorganized electrical activity in the atria, and the ECG shows an irregular rhythm with no P waves. Now, what about atrial flutter? Because atrial fibrillation and atrial flutter kind of go hand in hand, and patients that have atrial fibrillation and flutter will kind of go back and forth. Really, this also is kind of a disorganized or problematic, I should say, even though it's semi-organized, electrical activity in the atria. In an atrial flutter, what's happening is that the electrical activity is rapidly going around in a circular pattern through the atria at a very fast rate. Now, the AV node is still acting as the gatekeeper and is not letting every electrical current that comes to the AV node to pass through and depolarize the ventricle. At least we hope not. What it looks like on our rhythm strip or ECG is this, where you see QRS complexes that are narrow because the ventricle is being depolarized in the standard fashion, and you see P waves, but they're very abnormal looking P waves, and they're at very frequent intervals. So here's the example of the P wave, and you can see there's quite a few of them, and then the QRS complex. So the atrial flutter rate, interestingly, it tends to be very similar in patients. Now, it will go down a little bit with age, but most of the time, the atrial rate in atrial flutter is around 300 beats per minute, maybe down, or I should say complexes per minute, and maybe down to 280 in an elderly patient, but it's always up there and around that 300 range. The ventricular rate then is some divisor of 300. So if the AV node is allowing conduction of every atrial impulse, you would have 1-to-1 conduction, and your ventricular rate then would mirror your atrial rate, or it would be 300. That is infrequent though, and obviously that's not compatible with life in patients if they can have a sustained rate of 300. So what we frequently see is that it's actually some other divisor of 300, such as if every second atrial impulse is conducted, you'll see a ventricular response rate of 150. If every third atrial impulse is conducted, you'll see a ventricular response rate, or QRS complexes, every 100, at a rate of 100. So here's our P wave, and here's our QRS complex. And we see that the intervals between those P waves was about 300, and the intervals between the QRS complexes is a divisor of 300. But you have to be careful though, because atrial flutter, although it tends to be regular, can occasionally appear irregular. And that happens when the AV node allows the atrial impulses that come through to fluctuate from a 1-to-2 to a 1-to-3 or 1-to-4 ratio. So although the atrial impulse is staying the same, sometimes it's conducting at a 1-to-2 interval rate, sometimes it's conducting 1-to-3, 1-to-4, or some other divisor. And so you have to be careful because occasionally it can appear irregular. Now let's look at an ECG. And here you have a heart rate of 150, and you ask yourself, what is the rhythm? Well, a big tip-off is that the heart rate is a divisor of 300. So you know that you should be worried that atrial flutter is a possibility, especially if you don't see the rate changing on the monitor as you're watching the patient. But we want to use our rhythm algorithm to determine that. And our first question then is the QRS wide or narrow? And the answer here is, it's clearly narrow. So we moved in to our second question. Are the QRSs spaced regularly or irregularly? And the answer is, they are regular. And the next question then is, are there P waves present? And if you look closely, you can see that there are P waves present before the QRS complexes. So we do have P waves. So our options then are sinus, atrial flutter, and junctional rhythms. But we have our two follow-up questions, right? And we say, is there a P wave before every QRS? And the answer is we do see a P wave preceding every QRS. And then are the P waves up into and down in AVR. So here you can see the P wave in AVR actually appears up, above the baseline. And that's uncommon. Most of the time, the P wave in AVR in a sinus rhythm is going down. And the P wave in 2 is going down, which is opposite of normal. So this means that our atrial axis, as it's depolarizing, is opposite what we would expect. And so if that's the case, we then think that this patient has atrial flutter as their rhythm and not a sinus tachycardia. So in summary, atrial flutter is a circuit of electrical activity in the atria with a rate of around 300. The ECG shows a regular ventricular rate that is some divisor of 300, often 150. P waves are down in 2 and up in AVR, which is opposite of what we see in our sinus rhythm. Thank you.